Welcome to SurgBoards. Congratulations on almost being done and making it to the last step of becoming a board-certified general surgeon. You've all worked extremely hard and have made all your parents, family members, and friends very proud of your accomplishments and achievements. And no matter how much support you have right now, most of you feel very alone when preparing for this exam. Most of you have graduated residency and are either in your first couple of years of practice or in a fellowship, and you're preparing for the oral boards kind of on your own time. There is no residency coordinator sending you harassing emails. Your program director hasn't been blowing up your phone, and so the amount of preparation you put into this is completely up to you. Now, SurgBoards is not solely a content review course, even though there's a lot of content in our videos. And that's because that's not what you need. All of you have the content in your heads, or else you wouldn't be here. You've studied for the content in the form of an in-service exam every year, and it's the same stuff each year. It doesn't change. Not only that, but you've also taken care of countless patients. You've been their medical doctor, and you've been their surgeon. You guys are what the rest of the hospital looks to when they're in trouble. They call the surgeons. That's you. So, content acquisition is not your problem, regardless of what you think, and should not be your goal when studying for the oral boards. That was your goal when you were a graduating medical student about to start general surgery residency. You know the content. The goal now, as you prepare for the general surgery oral boards, is to effectively demonstrate your surgical judgment, clinical reasoning, and problem-solving skills. And you know why that's your goal? Because that's what the American Board of Surgery is grading you on. In preparing for the oral boards, you have to constantly practice verbalizing your thought process, not by passively reading a book. In the beginning, you'll ramble, and then you'll figure out a way to effectively communicate your thoughts regarding a case presentation. Think about when you were a chief resident and your junior resident presented a case to you. Which junior resident did you prefer? The one that told you everything you needed to know in a couple of minutes? Or the ones that rambled on and didn't really put things together in a concise or efficient manner? That's kind of how you want to approach the oral boards. It's more of a communications test and not a content test. You want to be able to clearly answer a question in a concise manner without saying, or rambling on and going back and forth. And the way to improve on that skill is by practicing speaking out loud, and we've built a novel technique to help you refine that very skill. SurgBoards developed a unique interactive module created by surgeons with the input of many graduating surgical residents to help you prepare for the general surgery oral boards. Our interactive module will help stimulate a real general surgery oral boards exam in which the examiner in a video will ask a question. The video will pause and then will allow you to take the place of the candidate and verbalize your response to that prompt out loud. You will then be able to read what a perfect, realistic response would be, and then hear and watch a candidate deliver that response, reinforcing that concept in 3 different ways. This then turns oral board studying from a passive process to an active process and will help solidify the very skill that the oral boards is testing you on: communication. Active learning is not a new concept, but is backed by a lot of great evidence. In Scott Freeman's study from 2014, which has been cited over 7,000 times, he and his colleagues demonstrated active learning significantly increases student performance in science, engineering, and mathematics, and those engaged in passive learning are 1.50 times more likely to fail than students engaged in active learning. SurgBoards is the first platform to offer an active learning approach to oral boards preparation. The responses on SurgBoards are all scripted and written in a way to demonstrate what a quote-unquote perfect answer and performance would look like on the oral boards. Some questions on the oral boards have many different answers that are right, and some questions have only one answer that's right. The answer you hear in our videos is an example of maybe one of several ways to perfectly answer a particular prompt. In having scripted answers, this will help you learn the correct response to a prompt and how to communicate your answer to a prompt, including all the nonverbal communication, instead of hearing or watching someone else deliver a poor performance with the wrong answers. With the interactive module, this is the closest you'll get to an actual mock oral board session with a live person, and we consider it to be the best way to prepare for the oral boards examination. And that's been confirmed by our high pass rate from previous SurgBoards users. Now Nothing beats practicing one-on-one, and if you practice 120 scenarios with a board-certified surgeon that has experience in medical education, you will all pass almost 100% of the time. But that's not practical. Most candidates practice anywhere from 1 to 20 live mock scenarios, if they're lucky, with a board-certified general surgeon. That could be either a previous attending from residency, a previous program director, current partners, or fellowship attendings. You should be reaching out to all these people and asking them. And once you're a board-certified surgeon, you'll pay it forward and help others. Candidates that perform poorly on the oral boards do so because a lot of the scenarios they were asked about during the real thing, they never truly prepared for. They may have read something about it in a book during their dedicated oral board study period, but they never verbalized any of those thought processes or clinical reasoning before the exam, and so they're doing it for the first time on the real thing. We've developed 120 scenarios, and really, it's more like 400 scenarios, because each of these are packed with scenario changes and variations to give most, if not all, the different ways that one surgical disease can be presented and tested on the general surgery oral boards. Because of this, the scenarios are a lot longer than the 7 minutes you get during the actual oral boards. If you know these 120 scenarios inside and out, and are able to answer the prompts the way the candidate answers the prompts, then it's, number one, unlikely that you'll be unprepared for a scenario on the real thing, because more than likely, it'll be covered in the scenarios we've carefully written. And number two, it's unlikely that your performance won't be anything other than excellent for that scenario. At the end of each video, there's a quick review of the scenario. And again, this isn't supposed to be for content review. It's supposed to highlight some of the key strategies, pitfalls, and principles you need to remember to deliver an excellent and confident performance on the oral boards. For those that haven't had a chance to look through the American Board of Surgery website, here are the main things to know about the exam, and all this information is publicly available. On the day of the exam, you'll have 3 30-minute sessions with 2 examiners for each session. During each 30-minute session, you'll be asked to discuss 4 cases, with each case lasting about 7 minutes. You'll receive an evaluation from each examiner for each of the 4 cases in the room. So, in total, you'll be asked about 12 scenarios in 90 minutes and will receive 24 evaluations from 6 examiners. There's no checkmark system for a scenario because, as you can imagine, that's a lot of different potential right answers and ways a scenario can play out. And there would be no way to objectively grade the candidate with a checkbox system. Instead, the examiners will grade the candidate's performance according to the essential attributes of a certifiable surgeon, listed below and defined on the American Board of Surgery website. The final outcomes, pass or fail, is dependent solely on the aggregate evaluation of the 6 examiners. And most of the time, exam results are posted within 10 business days after the final day of the exam. Board examiners are not trying to trick you. They don't want to see you fail, and most candidates will say that the exam was very fair after they're done. We've put a lot of thought into how to use SurgBoards, which we've detailed with the use of a study guide. There are 3 different ways to approach studying for this exam with SurgBoards, and that depends on how much time you want to give yourself to prepare. We have suggested study guides for 4 months of preparation, 3 months, and 2 months. Ideally, give yourself 4 months of study time, 2 months of light studying, and 2 months of intense studying. Based on your answers and the candidate's demonstration of what a perfect answer on the boards can sound like, take some notes in the Word document we provide, either electronically or print it out and write down your notes. In addition, we suggest that you watch the videos out of order so that you don't practice a GERD scenario, followed by a paraesophageal hernia scenario. That way you can reinforce some of those concepts, which are very similar in these 2 scenarios on 2 separate study days. And in the guide, we have a suggestion of what sequence to watch the videos in. Also, you'll find that in your portal, the videos are numbered, but there's no indication as to what the topic of the video is. And that's because we don't want to prime you for a particular diagnosis before attempting the scenario. However, if you want to study a particular scenario, you'll find all the topics numbered sequentially in the study guide. And lastly, each scenario has an option to just simply watch the video and not use the interactive module. And that's okay if you would just like to hear some of these in the car on your way to work. But we highly suggest to use the SurgBoards interactive module, in which you're forced to stop and verbalize your thought process out loud. The majority of your studying time needs to be an active form of learning, in which you force yourself to verbalize your thought process. Now, before you get on with studying, let's go over the basics of how to approach a scenario on the general surgery oral boards. In general, every scenario should start with a history, then a physical exam, then the workup, which can include labs or imaging, if applicable, and then treatment. Now, every scenario should start with a history and exam, but that doesn't mean that you start with the history and exam. A lot of board examiners nowadays give you all the history, or most of the history, and exam findings that you need up front. If they do this, do not spend a lot of extra time asking for history and exam findings, especially if they say things like, the exam is otherwise unremarkable, or the patient has no additional complaints or history to report. All that would do is tell the examiner that you're not listening. If they give you most of the history and exam findings in the case presentation, a reasonable opening can be something like, I got most of the history and all of the exam findings I need, but the one additional question I would have is if the patient has had a colonoscopy in the past. Or if you don't need any additional history, you can say something like, the history and exam are most suggestive of an acute appendicitis, so I would move on to getting blood work, including a CBC, CMP, and lactate. It's reasonable to tell the examiner what your leading diagnosis is based on the case presentation. They're not supposed to help you, but if they're trying to establish the diagnosis from the very beginning, having you say what it is really helps progress the scenario. Most examiners will want to focus on the workup, treatment, and complications, so it's reasonable to tell the examiner what you're thinking from the very beginning. The caveat to that is to not get locked into a diagnosis. If the examiners start telling you things that don't necessarily fit that diagnosis, make sure to broaden your differential and evaluate for other causes. In addition, anytime the examiner gives you the diagnosis in the initial case presentation, do your due diligence and make sure you agree with it. For example, if a primary care physician diagnoses hemorrhoids because the patient reported bright red blood per rectum, you still have to rule out cancer. So, in general, most cases will follow that sequence: history, physical, workup, then treatment. The exceptions are the trauma patient, where you'll start with the ABCs and the primary survey, or a patient presenting in extremis or with some sort of airway compromise, vomiting, blood, drooling, house fire with soot in the pharynx. In these patients, you should also start with the airways and ABCs. If the scenario is about cancer, as soon as you get the diagnosis, which is often done after some sort of tissue biopsy, the very next step will always be staging and presentation to a multidisciplinary committee. The committee will never give you the answer, and so you should always follow that up with what your recommendation would be. These are the general rules to the oral boards. This exam sucks to prepare for. You guys are all super busy. The majority of you are in a fellowship, focusing on your future specialty, and are less interested in things unrelated to your field, which is totally normal and understandable. Most of you have family or friends or significant others that want to spend time with you, and no one, other than your peers that are also preparing for this exam, can possibly understand the stress you're under and what this exam means. Stay diligent, stay focused, stay committed, keep a positive attitude, and remember that this is the one last major thing you need to do before you join the club of board-certified general surgeons. And lastly, not performing well on this exam does not mean you're not an excellent and capable surgeon. It just means you've performed poorly on the oral board examination on that particular day. Some of the best attendings you've worked with have failed oral boards. Some of the top academicians have failed oral boards. If you were unsuccessful on the boards in the past, take this time as an opportunity to be better prepared and maybe change the way you approach preparing for the general surgery oral boards, hopefully with SurgBoards. Good luck!